The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hey, good morning, George. It's Tuesday morning and we're back on the podcast today.
How you doing, Dr. Bravissimo? Today we have a fascinating topic, and our guest is Dr. Aaron Sin. And the topic that he'll be speaking about is one of my favorites, modern software for the independent pediatricians. So take it away.
Dr. Sin is a medical doctor that took a different path to care. After completing his medical degree at Stanford, he went on to work for McKinsey, a big consulting firm. Welcome to the show, Aaron.
We're really excited to be here. And thank you both for bringing me on.
Aaron, we always start by, why did you become a pediatrician? But you became a medical doctor and then veered off into a different path of helping the kids. How was that journey?
Yeah, it's been a really exciting and fulfilling journey. For me personally, a lot of what I've chosen to do in healthcare has been around impact. And earlier in my career, I realized that impact doesn't necessarily need to be through direct patient care. And so I explored alternatives to do, started on the more business consulting side of things, and really landed in the healthcare technology space, where I see a lot of opportunity to drive innovating change for practices that would be quite exciting, I think, for a lot of pediatricians.
So when you went to McKinsey, you had a medical degree, but no business experience. And then what project did you work with them?
A range of projects, really varied over time. So I've done work with life sciences companies, health systems, payers, private equity firms, clients that kind of sat in between those different areas. A lot of it was really working with larger organizations on strategic and operational topics primarily. I think one of my realizations there, and also pivoting a bit and focusing on what they call the healthcare technology and services space, is that one of the big constraints with how large organizations, and I think even small organizations too, can move and innovate in the current environment is they're constrained by some of the technology and tools that they're able to use. That really led me to leaving my role at McKinsey.
Wow. What was it like to try to change from Cerner to Epic at a big children's hospital? I can't imagine all the moving parts.
Definitely. It was a very complex, kind of multi-year process. This was at Lucile Packard's Children's Hospital at Stanford. They had a very long process from first deciding how they wanted to structure the transition, thinking through what were the different components that they would customize in the new EMR, and then going through rounds of training with physicians and staff, and then kind of a gradual rollout, really culminating in a go live in the inpatient setting where it was the most complex.
Yeah. You know what? I'm fascinated by when people change EHRs. In an office, it's complicated. I could only imagine how complicated it is in the hospital system. And this Cerner to Epic transition seems to be a very fashionable one recently. Why is that?
That's right. I think you're hitting on a couple of great points. One is there's incredible complexity when you're scaling it up in the health system side. A lot more users to think about, a lot more workflows to consider, a lot more kind of training requirements. And so you have to build that all into the underlying timelines that you set up, and of course, build in buffer too. I also think that it's easy to acknowledge that in the inpatient setting, you have a lot more acute care. The hospital never closes down. And so that go live period is a critical one where you're really transitioning from one system to another, and you can't have any downtime. I think it's been a fashionable transition because the Epic system in particular offers a bit more functionality that could apply more to children's hospitals. That's why I think you see a lot of systems making that transition, but it's not exclusively in that direction too. There are other systems that hospitals use, including Cerner and others, and they're continuing to use those in particular.
Now, I don't know anything about that children's hospital, but do they own outpatient practices too?
It depends on the children's hospital. Most of them will have specialty outpatient services that they own and operate. On the primary care side, you see a bit more variation. Some of them have built out their own primary care practices. Some of them have acquired primary care practices. I think the most common model that we see these days is they have affiliations with independent practices. Folks in their geography, they bring into their primary care network, work with them to provide improved contracting with the payers. And then those primary care physicians have better connectivity with the children's hospital, streamlining specialty care and referrals and so on and so forth.
Yeah, but Lucille, you said you worked on the inpatient. So I was wondering if they have a primary care arm that also switched over to Epic.
Oh, yes. So in the case of Lucille Packard, worked on both the inpatient and outpatient sides. Some of the outpatient was their own kind of clinic. Some of it was clinics that they had acquired over time.
What do you think were the pain points for Epic? Because Epic is a big monster machine for the primary care pediatrician. Other than changing. Change is always difficult, but some softwares are a little easier on the pediatrician than others. So what did you see as the biggest pain points that the primary care physician was frustrated with?
Yeah, the number one thing I hear, but not just specific to that one past experience, is when you're taking a software that's more set up for the inpatient side or the specialty pediatric side, there is more complexity than required in general pediatrics. Epic is well known for having a lot of functionality, a lot of flexibility to customize. I think that's why you see it increasingly adopted on the health system side. But when you port it over to the outpatient side for general pediatrics and you're not removing functionality, you have this kind of explosion of experiences on the interface. You have lots of buttons, lots of different colors, lots of different ways to do a particular workflow. And that can be really confusing. As you can imagine, you're thinking about running a practice, you're having kind of folks come in and out of the practice. You're generally looking to do a more narrow set of workflows, but do them really well. And having a lot of kind of buttons and colors on the screen really makes it a lot harder to do your day-to-day job.
Yeah, remember, we have a lot of customized notes in Epic for the inpatient side. And one day they did an upgrade. It opens up to your H&P, whatever you use. And one day they did an upgrade and something happened. It defaulted to out of the box H&Ps. I got this monstrosity of a template. Oh my God, I can't use this. It's impossible to use out of the box.
That's a great point. I think one of the realizations that we've had is when you have a really complex system with lots of different moving parts, not only is it harder on the user, it's also a lot harder to make upgrades and changes over time. Because if you think about it, you're making a design feature addition or modification or changing the user experience, you're really accounting for a lot of different workflows all in parallel and making sure that they will work once you make that additional modification. That's really tough to do. And that's why you also oftentimes see systems, especially older ones, more established ones, they're slower in making changes to their underlying code base. And so it can be months or sometimes even years before you can get in an upgrade. I think that sometimes that model works for health systems. It's a bit harder on the outpatient side because now you're talking about individual clinics, kind of smaller operations overall, and frankly, less capital to go request a change from an EMR company or any really technology company and have them actually put it into production. Right.
Yeah. So we have a pediatric dashboard, and as we've gone along on the journey, and it hasn't been that long of a journey. We started in November. To try to change the architecture, even on this is not a big project, is just nearly impossible because you change one field and you got to go reprogram every workbook within Tableau to match that field. And it's just hours and hours of work, and it's not worth it. We'll just use the workaround. So now I understand when the programmers say it's easier to just dump the whole code and start the house from anew than to just try to repair it because it's tough, isn't it?
House analysis, I think, is a great one, but it's all about what are the underlying foundations. Sometimes it is easier to just start with the new foundation than to try to renovate, so to say, on top of a more rickety foundation that you're starting with.
Just think about, you're too young, but just think about the houses that were built even in the 80s. They didn't have any cat wire. You want a secure connection to your computer in the office on the second floor. You got to tear through a bunch of ceiling just to get the wire to be plugged into your computer. And at some point, it's just easier to buy a new house that has modern technology into it, right? But that is the challenge of all software. Anything you touch, try to change, impacts a bunch of other stuff.
And I think with technology, you also have a lot of costs. Like when I did the renovations in my house, I ran Cat5 wire in my whole house. It cost money. And then what happened? Wireless technology came out. I never used it.
Yes.
I never used it because like 3 months later, the wireless came out and it was perfect.
This is nuts, right?
Yeah.
So, Aaron, where are we today with software for the independent pediatrician, one that's not aligned with a big hospital system or a private equity group?
I think that's a great question. And I'll start to frame it up in this manner. Right now, a lot of practices, there is a lot of variation. I'll acknowledge that. There's a few practices that are using paper for part of their workflows. Clinically is the most common area. But most practices these days are on some sort of software for what I call core functionality, being able to schedule visits, being able to write notes, being able to submit claims to the health insurance companies. I think a lot of the variation that you see is, one, are these the same system? Are they different systems that kind of somewhat speak with each other and are somewhat integrated with each other? And the other lens really to apply is, what is the technology stack outside of these core areas? Is the practice using something else for intake? Are they using something for patient outreach? Are they using something for telemedicine? And so you think about these considerations and how full experience looks like, how those systems may or may not be connected. I think, unfortunately, a lot of times you end up seeing an area where it's a bit of a piecemeal type experience. Sometimes the technology really meant to be an aid for practices and their staff and the pediatricians sometimes becomes a bit of a hindrance. My personal view here is that a lot of the software is somewhat designed for pediatrics, but none of it's really optimized for the independent. It's about taking a bit of a holistic lens that I'm really interested in personally. I think it's a bit of a gap right now in terms of what software vendors are doing. Unfortunately, a lot of them really consider pediatrics as a small part of their business. And so they're really taking software that's not really designed for pediatrics, let alone for independent pediatric practices, and try to force fit it in.
So
That
let me
seems-
take you.
That
take you
seems
back-
to be the running theme across medicine between adults and pediatrics. Pediatrics is always lumped into medicine and they squish it in trying to make it work.
Let's
That's
take you back to 2003 is to your point. 2003, I already had online scheduling for all my patients. And that was one piece of software that was hosted in the Ethernet, like modern hosting today. It wasn't Amazon, I think, at the time, but something like Amazon as a service. And that one backed up to a server in the office in case we lost internet connectivity, because in 2003, believe it or not, the internet connection wasn't stable. Then that had an API into the billing system called Metasoft. And we didn't use Metasoft for scheduling, we just used it for billing. The schedule all ran on a web browser. And then the third component, we used to have a legacy EMR, which I own the source code to, that worked on it. And that one didn't connect. So someone in the office, a nurse, had to put in all the demographics and medical history from the parent into the EHR so that I could see the patient. And of course, in 2003, there were no electronic prescriptions. So we had to have a printer in every exam room to print the prescription, sign it, and give it to the parent. But that was state of the art back then. And today, we still have the same problems. Some of the vendors that pediatricians use don't have an API with their EHR. And so you're juggling in somewhat a similar fashion. I did always that e-appointments allowed me to have a cloud server and back it up into my own server. It doesn't happen as often anymore, but when your internet does go down and you're all in the cloud server, that is just nerve-wracking. Then you're on cell phones or tablets trying to see your schedule and see what's going on.
Yeah.
And that's happened to George once or twice, where they have to go to paper and everybody freaks out.
We were used to that because we started our electronic journey in 90s. Yeah, we got the practice management stuff. So that went on for many years, 10 years. And then you had to add the EHR. So they had to have these complicated T1 connections back and forth, very expensive. to
$100 a
get
month.
the third part to connect the EHR and the billing, and then you added the patient portal, which was very good. Remember that Concierge MD product? I think that was the best product ever that they killed. They were ahead of their time, which had online scheduling that would pull your schedule into there. People could make their appointment. Their thing was, if a patient wakes up at 3:00 in the morning with fever, ear pain, they could look up some information for fever, ear pain, and keep the appointments open for 9:00. And they can just pick that appointment at 9:00 and fill it up, as opposed to waiting for the phone to ring.
Yeah.
But that died. But all these connectivities, when they worked, they were fantastic. But when something broke, you had to figure out, was it the internet? Was it the EHR? Was it the practice manager? Was it the portal connection? Which interface was broken? So we were good at going back to paper.
Yep. Aaron, and there's a lot of data underlying all these systems, whether it's the billing side, the EHR, even the Fresias of the world. They're collecting a lot of data from your practice.
Question.
And how do you see the software for independent pediatricians, meaning what Dr. Wixom talks about, the key to monetizing data, which is data, insight, action, and then value?
Yeah, I'll unpack it a bit. I think you're hitting on a lot of great points. The first starting point is really the underlying kind of data that your system's able to gather. A lot of that kind of comes down to foundationally, what's the underlying data architecture for a system that you're using in your practice? So, my perspective here is that's in many ways is almost the single most important part. If you have great underlying data, there's so much that you can do with it. What we see and what I see as a bit of a kind of modern perspective on data is leverage first a true interoperable standard. FHIR is the latest interoperable standard. That's probably the most modern one there. Covers a lot of the underlying clinical data in particular. Generally collecting structured data, even outside of the clinical realm, becomes really important. Gives you a lot more information to work. Then you also have to think about, how are you working with these data that you're capturing? Are you able to track its changes over time? Are you able to tag certain data elements in a certain manner? Let's say, get to support adolescent confidentiality. You can imagine that when you have a good data approach, it unlocks a lot of downstream use cases. Then you can take the underlying data and analyze it, drive reporting. I think a really good piece is connecting it to action and value, which is really a realm of thinking about what's most valuable information that I can act on, and how do I make it easy to act on that information? It's a bit of a change from, let me take information, process it, run a report, decide what I see in the report, and then go and take an action, versus why not just automate that and build that into the system? So
Sure.
there's certain
I'm
things
going
that
to
you wanna
interrupt
build.
you. I'm going to interrupt you just for 1 second, right? So we're going to get on the weeds. Right now, most data that you can pull out of your quote unquote EHR comes from claims made. So it comes from your reporting CPT codes with an ICD-10, and that's where you're pulling your data from. Sometimes those reports are not accurate. And why is it so hard to get data actually out of what your EHR is? Because that's what I could see a patient, I could talk about their sore throat, their earache, their diarrhea, but I'm only going to report it as a 99214 with a Cepheid test that was negative for everything. And that's it. But the fact that the kid had ear pain and sinus congestion and diarrhea all at the same time doesn't get reported, doesn't get seen. Why is that? And how does that make the data that I'm measuring somewhat inaccurate?
It's a reflection a bit of what is captured in a bit more structured manner, what's a little easier then to therefore extract out. Every system is going to have diagnosis codes and billing codes. I think you're lending to a natural question. What's the additional kind of clinical history, clinical context that you're able to capture in a structured fashion? How can that be used to drive downstream reporting? I think a lot of it depends a bit on how the system is set up to capture this clinical information, how the note writing experience in particular works. It's also an element of what's the underlying technology that you're using to pull out insights from this data. If you're bringing in natural language processing, if you're bringing in new age AI capabilities, you're able to extract a lot more information, and that can really help. Part of it is also What if you just had an approach where you captured a lot more granular pediatric medical history? You're getting beyond diagnosis codes and you're capturing richness on the patient's, let's say, birth history applies for a newborn. Once you have that in a structured fashion, then you're able to work with it in a lot more facile manner.
Yeah, because some EMRs do have it. They have these tags. I want to see the patient back in 2 weeks, or I want to see patients in three months, or whatever is that you tell at the end of the visit in a little box. But in the ideal world, when we start talking about automation, if I write on the note, I need to see this kid in 2 weeks, there should be an AI model that reads my note and makes sure that all the patients I said I need to see in 2 weeks, come 2 weeks from today, have been recalled and have an appointment. And that would be a way that I can turn data into action, improve, because value in healthcare is improve care and improve margins for the practice.
Just at the top of your license, and I would say that applies to whether you're a pediatrician or the practice staff.
Anyway.
You just float all the way through, reach out to the patient, allow them to self-schedule. Only at the last step, if you really need to call someone, they haven't scheduled that next well-child visit. But this is a much shorter list than calling everyone and waiting for them to call you back to schedule.
Yeah. But even now, child, sometimes you want to see someone back in 2 weeks or 4 weeks, whatever it is. And there's just no way you can keep that in your head. And there's no easy way to run a report and see who didn't show up. And it becomes too labor intensive and you just have to give up. The ones you're really worried about, you ask them to come back in a day or two, you remember those. But the ones that the asthmas, the obesities, the high lipids that you want to see every 3 months, if they don't schedule the appointment, there's just no way a human being can remember that. Unless you got 10 patients, then yes, of course you can remember it. But if you got a busy panel, you're not going to remember all these things that you could do to improve care because if the parent just doesn't schedule the appointment on the way out.
That's right. So automation, I think, is really the way to do this. Able to provide better clinical care, bringing patients in, especially those who need to come in sooner or more often. It helps the practice perform financially too, when you're seeing all the patients that you really want to see.
Yeah. And then how do you design software for independent pediatricians? And Dr. Wixom uses a term that I really like, data wrapping. And it sounds very complex, but basically data wrapping is the concept of using data to delight your customer. And when you're talking about software, it's not, but it should be the clinician and the patient who are top customers, not the hospital, health system, private equity, financial system, CMS, or the health plan, because they can get the data they need from somewhere else. Honestly, they could. They just turned us into secretaries as opposed to working at the top. And she says there's 4 things that software needs to do to delight the customer. They need to anticipate, advise, adapt, and act. How do you see a modern piece of software for pediatricians doing that for the clinician and for the patient?
That's a great set of points. I think a lot of it is underlying how do you package the information in a way that's usable for pediatrician, and how do you make sure that information gets delivered right when someone needs it? A lot of that gets to fundamentals of product design, user experience. If you build the software in a way that you've really gotten deep at understanding what are the critical workflows, presenting that right kind of patient summary, let's say, in the context of a visit. Or let's say when mom or dad calls in, front desk is able to pull up all the information about mom and dad, how they've interacted with the practice, who are the kids that they bring to the practice. That's all underlying information that first has to be stored in the system. And 2, you want to make sure it gets processed and presented in a most actionable way. That really hits on the anticipate of advise components. Being able to adapt your system, some of it could be directed by someone who's building the system and upgrading it over time. Some of it is also building intelligence and automation in the system. So when it realizes that you're in the particular clinical workflow or a particular task and you're reviewing a result and may want to take certain actions, bring those experiences in automatically. And that gets to the last part, allow you to act, whether the acting is reviewing a result, messaging back the patient or the parents, completing a note, completing the billing. It's all about packaging that together into kind of one streamlined experience. It does take a lot of modern technology to power that. And I think that's part of the complexity.
Yeah. So let's break it up because there's so many moving pieces, right? So if someone calls for an appointment, which I argue that should never happen unless it's a dire emergency, they should be able to schedule their own appointment online for almost everything. Start with the well child exams. There is no liability. Your well child exam is every 1 year. Because I'm just saying over 4. You just have to come in every year. You have an appointment. It's not good for you. You can change it, but you have to come in every year. But let's say someone calls in, and wouldn't it be great if the person scheduling gets presented to them on their screen what that patient owes the practice, what their insurance is, or what we have as their insurance, whether it's validated or not, and what their deductible is, so that the conversation can be quick and effective for the patient. I see that your insurance is no longer Blue Cross Blue Shield. Let's update that. I see that you have a balance of $200 that went to your deductible. How could we take care of that today? We have Visa and MasterCard, right? That would be that adaptability of the software to present to the scheduler to do best practices in scheduling. But the physician needs something else, right? The physician needs to know a summary of the encounters with this patient, because maybe it's a very healthy kid and rarely comes in for anything. And so I just need to know that this Johnny is 12 years old, healthy, vaccines are up to date, hasn't been in the hospital, doesn't take any chronic medicines. And that summary that is 2 or 3 lines long saves me a ton of time of having to look through fields and old notes. And then we had this recently with one of our friends. His daughter got a pyelo, and the first culture positive, the second culture negative, which is what you expect. The nurse practitioner that takes care of the practice that his daughter goes to called the mom and said, you can stop the antibiotics at day 4. Okay. That nurse practitioner should have gotten in the AI. Here's the history. This patient has a pyelo, is on this, stop being febrile on this date. We last saw them on this date. This is their follow-up culture number 1. They should complete 7 to 10 days of antibiotics before you stop them. And it would have been better quality, better customer service, and a quick interaction.
You know what, Herb, I'm going to push back on this.
Yes.
I think a lot of the EHRs already have a lot of those steps that you mentioned. And a lot of the disconnect and a lot of the problems still come back to the human. Scheduling online has been something that's been around for a long time, yet very few EHRs do it. I don't think it's because they can't do it. I think it's because they don't want to do it. So when I've asked them outright, why don't you guys do it? The answer was the doctors don't want it.
Yes.
Doctors want to be in control of their schedule. Makes no sense to me. Second thing, you're talking about the summary. A lot of the EHRs have the summary. Am I, as a physician, going to look at the summary of a well checkup that I'm going to have in 3 months from now, 2 months from now? I'm not going to remember.
What summary are you talking about?
You're saying the summary, he's good, he's up to date with his vaccines and things like that.
I honestly, I know you use OPN as a great product. I have never seen an EMR that is using currently NLP to create a summary of the patient's prior visits. Never seen that.
They do.
They have a bunch of structured fields, allergies, vaccines, all the medicines they've been on for 13. So I can see what medicines he was on when he was 6 months old. What does it matter to me? I don't care that he took some erythromycin for conjunctivitis when he was 6 months.
Yeah.
What I care about is, has he been in the hospital? Did he have congenital heart disease? And I want that summarized quickly when I'm seeing him for a sick visit.
Yeah.
And he's not my patient, he's your patient, but I'm covering today. I'm in the urgent care, and I want to see, is there any problem with his heart because he's got a big scar in his chest, or is it all been resolved?
Yeah, so that's the problem list or the face sheet, or we used to do that with the paper charts, Aaron.
Yes.
About this stuff. On the front of the paper chart, we used to have a label where all the vaccines used to be manually written because you're always looking at the vaccine record and you want to flip paper. you couldn't read the things that the people signed. And then you used to write allergies on it, put an allergy sticker, you'd have a problem list. So all the summaries that Herb is talking about, you used to put on a paper chart
and
a
a
summary
chronic
sheet
and
and
a
chronic
chronic
conditions.
and a chronic med sheet. Remember, there's a
Chronic med sheets too, yeah. So
behind
that's
the
a summary
problem
sheet. That's an easy thing for EHRs to do. Why they don't do it, I don't know. Nobody thought of it.
I think if I merged what you're both saying is, I think there's an element of how is something executed, right? Scheduling is a great example, right? Online scheduling, it's a no-brainer that having some form of it is probably good for practice, probably good for the patients and the family members. But the question is, how well do you do it? Are you able to configure it so that you constrain it to what works for the practice?
Yeah.
You probably don't want too many sick visits or too many well-child visits. Are there other constraints that you want to set up? I think that's one example of where setting a higher bar for what you want to achieve, that's really the way to make it a lot more functional, a lot more usable. Summaries, I think, is a great example. Generating static summaries with underlying data fields that you can pull in from a patient's chart or from one of their past visits and notes. That's the current state. I would say relatively straightforward, but being able to contextualize it in the context of a particular interaction. So someone's calling in about a certain med rebill, right? To present the contextualized information there. You're looking to make your referral to to a specialist, present the contextualized information that specialist cares about. It's really where I would say the next stage of innovation is moving to. And that requires better technologies around NLP, generative AI, of course, workflows as to how someone can critically review some of those summaries too. It's really an extension of what I see as some of the challenges in existing systems. Alert fatigue is something that often comes up. Of course, I can just build in notifications left and right in yellow and red colors on something that you should pay attention to, or that's something the potential problem. Well, guess what? If that's not set up well, and oftentimes those miss often. And then once it misses a couple times, your brain is trained to just ignore it. And that's why it's got to be really critical about what you present, how you do it, and make sure that execution is there.
Yeah. And that last piece that you mentioned, two pieces more. Most EHRs will give you a pop-up. You owe this balance. You have this. It's that the human doesn't engage it. Okay. And the fourth and final piece that I want to unwrap is the statement about the pyelonephritis. You have a kid with pyelonephritis and you're reporting a negative follow-up culture. I don't know, but I don't think I would stop the treatment on that kid. I would find out, is the kid doing okay? Is he febrile? Is he not febrile? Do I need to bring him back in? Or do I say, okay, we're doing better. Let's finish up the treatment that the doctor started. I think that was human. I don't want to say mistake, but mistake.
Yeah.
And not with the computer.
Software has roles to help make things easier for practices. It's also an angle to reduce errors too.
Yeah.
I think how you present that information is really important. I don't think software should tell anyone, go do this or go do that. Give folks the information that they need to act on. If it's very obvious that a certain direction, what you should do, right? Especially for non-clinical workflows, really shunt the user in that direction. In certain cases, you probably just want to outright automate.
Right.
So why leave a user the option to call a patient to remind them to come in when you can just send an automated text message to that patient and just let them know to come in and give them the ability to confirm that they're going to come in. They're having this experience outside of healthcare anyways. Airlines, their restaurant reservation, just bring that into healthcare, modernize the experience.
Yep.
The problem with that urine culture, which I've always said, I don't need to see another negative urine culture. But there's the complexity of medicine. So I am correct probably 95% of the time that I don't need to see another urine culture that's negative. There's nothing to do with it. It could be automated that says your urine culture is negative. You don't need to worry. And that goes out the text message to the parent. And it gets put in the chart and I don't even have to look at it.
Yeah, medical legally, you can't do that. You always have to have a human-doctor interaction. Otherwise, you will have rise in the machines and you will have medical errors.
You don't have to have a doctor.
Or somebody.
It is as old as I am old. These were all taken care of by an LPN or an RN or an MA in the office. And they would take all these backup throw cultures and all these urine cultures that were negative, and the patient wasn't on antibiotics. There would be a protocol. It would be written on the chart, put on the chart, and I never looked at them because I didn't have time for it.
Oh, yeah, the doctor shouldn't have to deal with this.
But we do in the current EMR. But the problem is the one-off, like this one, this nurse practitioner
Should have realized.
didn't know the history behind this child, that this wasn't just, it hurts when I pee. Okay, your UA is normal in the office. We're going to culture it. This was actually a pilo, and there was a follow-up culture to document bacteriological cure.
Uh-huh.
And she just saw in the inbox negative culture.
Yeah.
And she hit the button, called the parent, and said, your culture's negative. Didn't bother to ask, how's the baby doing?
Yep.
The mom would have said, oh, we're told she had pilo. She's on antibiotics. The fever is gone.
Yep.
And she would have said, oh, okay, then finish the antibiotics and we'll see you at the end of the antibiotics.
Yep.
She just automated. Oh, negative culture. George, please stop the antibiotics. The culture's negative. See you when you need us. Bye. Boom.
Rise of the machines.
But that was a human being who did that.
I know, because she didn't follow.
So,
That wasn't a physician, though.
no, it was a nurse practitioner.
Yeah.
But that's a problem with the complexity of medicine. 2
Yeah.
plus 2 doesn't always equals 4. It equals 4 95% of the time. And then there's the 5% of the time that it equals 6 or equals 1. And
know,
that's
I think
where
the point of like when you automate too much, it can actually lead to some errors. The
yes.
question is, how can the system be responsive to the fact that, hey, maybe this does require a higher level of, and I think that's always going to be a bit of a tough balance to achieve. And it's something to be really thoughtful about. Think about design of your product. How will it actually be used by the users is really important. Not just how do you want the users to use it or how do you intend for folks to use it?
Yes. But to George's point, he's right. The more we take the human element out of the equation and we automate efficient and effective we are, because we're humans. We have emotions. Some days I don't feel well. Some days my schedule has 30 or 40 patients. I don't want to do one more thing. But the machine doesn't work that way. If the machine has to make 50 touches to remind people to come in for their well child exam, it just does it. And so that's whenever you can take a process and safely automate it, then you get better value just because there's less error. There's always going to be some error built in humanity, which is what makes humans fun, right? But
yeah,
it's part of it. So Aaron, how do you see NLP and AI interfacing with all these things that we've talked about?
I think the role of NLP really is in this context to help extract out information from your clinical and even administrative system that you use in a pediatric practice. NLP in itself is allows you to take unstructured data, start to map it to structured data concepts, pull out themes and concepts. I think how you pair this with the new age generative AI unlocks a lot more downstream use cases. You can use this to help you write a note. You can use this to help you draft a response to a patient message or a parent message. You can use this to build a dynamic patient summary in the context of a particular message, in the context of a particular phone call. It unlocks a lot of possibilities. The constraint is going to be a bit, how do you set up the generative AI, make sure that it's properly constrained, properly prompted? What's the underlying data that you're feeding into the NLP side? The more unstructured it is, the messier it is, the harder it is for the system to interpret.
So let me just, for the sake of people who don't know what structured data is. So in my mind, structured data are CPT codes, ICD-10 codes. That's an example of structured data that everybody understands. And that's found in your billing part of your EHR. In my mind, unstructured data is what's actually on most of the note that has been typed in there. And that's where we haven't yet been able to harness the notes in there. Like when I got the template and I write, this child is obese, and last time his fasting insulin was almost high, and his hemoglobin AC1 is 5.5. We're going to repeat them. If they continue to be high, we should consider metformin for it. That is unstructured data, but that really is the value of that patient visit and that note. And that's not going to be reflected on the ICD-10s or the CPT codes. That's what a good explanation of what structured data is, Aaron?
I think so. I would extend it a bit in the sense that some of the more sophisticated systems do a bit of a better job to capture structured data beyond diagnosis and CPT codes. For instance, if you're able to utilize features that capture more granular pediatric history. So you're working with a teenager, you're capturing, let's say, sexual history, menstrual history, social history in structured fields. And then those structured fields aren't just data points that map to underlying code sets. You can use SNOMED codes or Lloyd codes, which are really additional code sets that go beyond ICD-10. Then you have a lot more of a granular information you can work with, in addition to what may be documented in a more free text format within the node.
Okay. And then for those other codes that you mentioned to work, that would all have to be automated, right? Because I'm not going to sit there and try to figure out one more code. I'm already out of my mind trying to find the right ICD-10 code.
That's right. You don't need to go find a specific code. So let's say you documented the history elements, system maps it to the underlying code sets, and then you can work with it from there. The nice thing is you can then take those codes and then drive some downstream reporting that you may need for value-based care or some other purpose. But having that structured entity really helps.
Yes. Aaron, and I make fun of Facebook and email because if you talk to young people, they roll their eyes when you talk about email or Facebook. They're like, yeah, that's what my grandfather uses. Are patient portals what my grandfather uses?
In many ways, I would say yes. I think there's some good concepts to pull from it. But the way I would frame up more modern and forward-looking patient engagement is I would, first of all, think about it as family engagement. Think about not just engaging the patient, think about engaging mom and dad, another caregiver, siblings, discrete individuals, different needs, right? Different focuses. Also think about bringing in a bit more of an omni-channel experience where what we're really speaking here is connecting different engagement channels all in one single interface and experience. So front desk gets a phone call or they make a phone call to, let's say, a parent. They're able to see the messages that may have come in through the portal. Maybe they see the messages from the text side. They see some summary of the past phone calls. Of course, they see visits. It kind of gives up a lot more of a complete view. Even short of that, move to where patients are these days. Folks are a lot more interested in a smartphone mobile-based interface. So you're able to dynamically text with them, give them quick links to confirm their visit or to complete that screening tool. You're meeting them where they're at, not logging into a portal and then viewing a message or going to a separate place to complete a screening tool. It drives a lot more adoption. I also think it's just great practice. Like you're meeting where patients, especially with lower beams, are at. We know in the United States that smartphone adoption is way higher than desktop or laptop access. I think that's great as a pediatrician to solve for that through better technology.
Yeah. Some people really love the portals. I'm annoyed by the portals. It's always a pain. I can't remember what my password is to get logged in. And then on my dad's side, he's 85. He logs into his portal and none of the information is curated for his consumption. So he's a lawyer with an MBA and he sees that his creatinine is, I don't know what it is, like normal is 1.2 and his is 1.4. And he's freaking out because it's a normal result. Because it's not curated. It doesn't say for an 85-year-old man, we don't know what a normal creatinine needs, but it certainly is not going to be the same as a 6-month-old. So we're not worried that it's 1.4. You're not acidotic. Your potassium's not up. You're urinating every day. You're doing pretty well. And it bothers me because I think that's what the doctor's job is.
That's called medical decision making.
Yes, to put it into context, right? An alkaline phosphatase of 400 on a child that's growing. So what? I'm not excited. But you give me an alkaline phosphatase and me or 400, I'm looking for bone cancer or liver cancer. Yeah. I'm not supposed to have a high alkaline phosphatase.
But what happens in cases like that, and I'm seeing it with patients, is they're looking that up on Google and Google will tell you worry about cancer.
You're right, and you're nuts. You're going nuts.
Yeah. We deal with this all the time with lab reviews. They're minimally elevated and we know that they're normal and you end up talking to them. And fortunately, we do it through telemedicine. So you're talking, you're analyzing, you're making medical decision making. and you're generating some income, which is fine.
Yeah.
But in the old days, when we used to just call up, yeah, your labs are good.
Yeah.
And there was a lot of little variations that you never told them about.
Because why give somebody anxiety when they don't need it?
Yep.
The same example, I probably shouldn't be talking so much about my dad, but he had a cardiac cath. The first time he's had a cardiac cath in 85 years. He doesn't have coronary artery disease. But when the invasive cardiologist went to dictate his note on Epic, there must be a field there that says, we'll review the results with the surgical team. It was just the template. And he didn't take that out. And my dad saw that and he called me and was like, what surgery? I don't want to have open heart surgery. I said, Dad, we talked to the invasive cardiologist in the cath lab. He said, no one's going to open you up. No one. That's just a templated note. For God's sake, please stop reading every note like you're a lawyer in litigation. You're going to die from anxiety, right? But that's the kind of thing I'm talking about, that sometimes the patient portal becomes more of an anxiety-provoking thing for the patient because there's no translation of this is not important, or that's just on my template. No, I know you're not going to have heart surgery.
Yeah. I think it's a question for short translation. How can you contextualize information? Results are a great example. If you can just add in the pediatric ranges, right? That will probably help in some of the circumstances that we're describing, versus just the adult ranges or ones that you can look up. I think it's also an element of how a lot of portals work with medical records. It's a bit of a binary experience in the sense that either you have access to the records or you don't. Right? And sometimes in pediatrics, it's also binary record access between mom and dad and, let's say, the adolescent. Being able to more fine-tune this, whether it's a workflow so that you release certain results with the right interpretation to the patient or the parents, or you're tagging information so that you're not releasing adolescent confidential information to the parents, but also not removing full access to that. That kind of balance, I think, becomes important. The reason it's so tough these days, it gets back to an earlier theme what we discussed. It's how do you manage that data? How are you able to track it and tag it and store it? Oftentimes dictates how are you able to expose that information or not. For instance, if you're structuring your clinical data in FHIR format, you can use FHIR APIs and to expose information or not expose it pretty readily. But if you're not, it becomes much more of a binary constraint that you have to work around.
Right. Complicated. This EHR stuff is complicated.
Yeah,
we got to go back to paper.
You touched on something that's pretty interesting. It's a pretty complex field of FHIR standard and APIs. My experience with APIs, it's all about the money. If I'm a small practice and I want an API, I don't say between WhatsApp and PCC. Okay. PCC looks at me and says, yeah, that's a great idea, Herb, but it's going to cost us $50,000 to do that. We're never going to make it back. And you're the only one requesting it. And then it ends. That's the end of the conversation. Is FHIR standard going to allow for these API to be bidirectional and inexpensive? Or is there still going to be WhatsApp saying, we charge $25,000 for this integration. It doesn't matter if I have to write a line of code or not, but that's what it costs.
Yeah, there's a lot of pieces that I think you're referencing. I think there's a couple of points I would make. It depends a bit on where the regulations are. As regulations push more kind of FHIR standards and other general interoperability requirements, I think that's going to nudge EMRs and other software systems in the healthcare space to move in that particular direction. One point. I think it also depends on what's the underlying software that you're using. More modern software is going to be well more set up to meet these interoperability requirements because they were solving for in the first place, or they baked it into their underlying approach. Legacy software, it takes a bit more time. You're going to have to take your underlying data, map it to a new standard, then figure out how you're going to expose that information in an API, a directional API that builds in more complexity. You think about who has authorization to the information. And that's why you get the push to, we're going to have to charge an implementation fee for that particular service.
Yeah. Yeah. So do you think some of it will go away, some of that cost? Because it can be quite high. These APIs can run $5,000 to $25,000 depending on what you're trying to do.
I think some of the costs will go away over time. It will vary a bit based on, again, where regulations go, what underlying system you're using, what's the overall kind of demand. I will say this as a more general point. More modern software is oftentimes delivered in what we call a software as a service model. And what that means is the incentives are for the software company to build kind of one fantastic piece of product that they can keep using across, let's say, multiple practices and keep improving over time and building that out. A more traditional model is a mix of kind of software almost as a customized build and deployment per health system or per practice. It leads to a lot more complexity because then you really have different versions out there, different deployments, different sets of modules. It takes a lot more to maintain. And then it naturally leads to a bit of a business model where if you want to make an upgrade, make an implementation change, you charge for it. Whereas in the new age model, they're really investing all the dollars back into just improving the product, making sure it's one product that folks can really use. Of course, you can still configure and customize it a bit. And so it's not just a technology question that we're talking about. It's really a business model too.
Business model, yes.
Yeah.
And we touched on this just briefly, but the world is mobile, right? We see that in our podcast. Something like 85 to 90% of people that listen to the podcast are using it on mobile.
Mhm.
For our demographics, 85% are on Apple phones. Just this is what it is. So reaching the patients on mobile is key through texting or the communication apps, right? And that has not been done well so far with most pediatric software.
Yeah, that's right. I definitely think that mobile is the way to go. I wouldn't even say it's exclusively for the family members, right? Even doctors and their staff want some mobile access to be able to quickly read a message, respond to it, check out their schedule. And I think this gets at a critical kind of software concept of making sure that your application, your system is responsive so that it can work as well as on a desktop, a laptop, or a tablet, and also on the mobile side, optimizing, especially on the mobile side, key experiences that you're solving for. Mobile isn't just a question of how you access the information. It also unlocks certain things where, for instance, for a patient or their family members, they don't need to log into a portal, navigate to a specific section just to figure out what came through in that generic email that notified them that something happened. Mobile experience without even a login, be able to confirm your visit, be able to complete a screening tool, be able to schedule a visit, that becomes really powerful. It drives up that engagement. That's really critical. And it reduces the work for the practice staff. If you can get 80% of your visits scheduled in this manner, that means you have 80% less scheduling phone calls to make.
And what is the role of video in mobile? Because engagement is much higher when video. So if I could record, hi, this Dr. Bravo from your practice at RBK Pediatrics. Johnny's RSV, flu tests, and strep are negative. You just need to keep giving them something for the fever and gargle with salt water and let me know if they're not any better or if they are not improved in 3 days. That people will listen to that video message a lot faster than they will if I type that on a text.
That's right. That's right. And I think that you're getting a great point, which is video not in the context of a telemedicine visit. It's video in the context of communication with the patient in between visits, and how can software help you set up and record that video pretty seamlessly and get it out the door? Or in certain cases, I think the technology is rapidly approaching there. How can it automatically create the video for you, right? Leveraging existing videos that you may have created to drop in that message. Patients, parents, they're real use videos, whether we're talking about Instagram or TikTok or other things, right? Like that's where the world is at. And so it's really a question of meet folks where they're at. They're going to be happier with that care too. It feels a lot more connected to their doctor.
Yes. And then it goes to three things that we've learned from talking to people. One, it can't be a link because the young, smart people do not like to press on links. Even though it'll say RBK Pediatrics on top, they're like, this might be a scam and God only knows what will happen to my phone. Yeah. So they won't do it.
I'll push back on that. We do that with the idea we had at the Pediatric Lounge with the anticipatory guidance and vaccine. What's going to happen at your visit? We send it to them. And I was afraid that they're not going to push the link because I don't sometimes. So that's why we wrote in the message, the doctors of RBK Pediatrics will like you to watch this video before your visit and then put the link. not just the link by itself. They won't touch that. And
Yeah.
our uptake on it was really good. People watch that stuff.
I think it'd be hybrid approach. It's easier to access information if it's just a link. Of course, you need to build trust in the right way, but you can also move people to your application. So you have a dedicated app on the smartphone that usually will provide even a better experience. You can end up notifications. It's one leads to the other is how I want to think of it.
Yeah. So a lot of the portals have that capability, but that requires now that the patient, they get a text message. There's a message for you at the portal of RBK. You got to log in to see that message, just like your bank. You got a message from Chase Bank. Log in to see your message. It's all HIPAA and security. They don't want to put the message out there. So the workaround is a simple text.
Yeah.
Now,
But I do think video and texting
it's good.
and very short messages, and if it's the face of their doctor telling them, imagine that your well child exam labs are normal. We'll see you back in a year. Now, don't tell them to go log in, look at it.
Yeah.
You review them. They're normal. It's one click on the computer. It gets sent out to text message. They're not going to call you back because the LDL was 101 and not 100, and everybody's happy.
Yeah.
What do you think, Aaron, is the role of scribes in the future?
I think it's really going to change where the generative AI technology is at. I see a world where scribing will still exist, but it's going to be technology driven versus individual driven. You can imagine an experience where software is able to interpret and understand the conversation you're having with the patient. And by the way, you not needing to note up also gives you more time to spend with mom and dad and the patient, do an exam, etc. And then it's able to draft a note for you. But it's not just a transcription, right? I would say that's more old age technique. It's more of a summary and a synthesis of the conversation that you had, taking in underlying data that you have in the chart about the patient. You can, of course, constrain and direct how AI will write the note for you. So if there's a particular way you want to, let's say, document a well child visit at a certain age, AI can draft a note against that template, but also capture more details than you will probably ever put down than if you're writing. Save 75% of the time, get a note that is synthesized in a way that works for you. Seems like a great approach, sets a higher bar.
Yes. And your vision, you're more of an Apple guy, right? That you create a garden with a big wall and you curate the best in practice apps for that garden, as opposed to Google, where if you just build an app, it gets on the store and who knows if it works or not with your system, right?
Yeah.
I would say it's probably somewhat in between. Like we see a big part of our role is to build seamless experiences for the user full stop, right? Pediatrician, staff, kind of patients and family members. Some of that is we're going to build in-house. Some of it is we're going to connect with third parties, whether it's faxing or prescribing or electronic labs. Make it so that you as a user, you don't even know that those capabilities exist there. I think that's really our primary focus from an approach standpoint. It's not really about true open source or really enclosed garden. We believe fully in interoperability, right? That's why we have our APIs. For the parties that should have access to, should be easy to pull data in from us. And also, it should be easy for us to pull data into our system that would help.
Okay. And then we touched a little bit on this, but, and this is just my bias and unhappy experience. The EHRs of today are not built for the clinicians. They were built for the government and the financial accounting department at the health system. Yeah. What is the importance of user design in EHRs and its role in being more effective, being able to bring value to your interaction with your patients, and really fulfillment of the patient visit, where you don't feel like you're a monkey pressing on a keyboard just to get through the visit?
This is a great point that you're making. I think one, it's a combination of underlying objectives with an EMR system and really how we think of it as pediatric software for the independent practice. You do need to solve for the clinical workflows and experience. You also do need to solve for the financial side too. So whether it's billing the insurance companies, processing those family payments, both are important. I think the question is, how can you make sure that you don't just do one over the other? Or as you mentioned, just do the financial side and make the clinical side secondary. User design becomes really important in that. A lot of existing systems, you notice a lot of buttons, a lot of colors, a lot of ways to do the same workflow. And that's really not a hallmark of what we call modern product design. Modern user experience should be clean, simple, and elegant, a lot easier to learn. Take that into the workflow. As a product, you want to have a strong opinion. What are the ways that this should work well and work efficiently, and still give some user flexibility, and then really make that a really strong and good experience. Can you bake in automation so that you can also streamline certain components so that you don't need to manually do that? Can you build in thoughtful notifications so that you're prodded to move in the right direction? You're prodded when there may be a mistake getting made, right? Or there's a warning. And a lot of that is really about configuration in the context of a particular clinical visit. I think a pediatric specific approach is important. You see a lot of EMRs, especially more generalist EMRs, where they just design something for any outpatient experience and then squeeze it in for pediatrics when it's pretty different than the adult side. And then you see some of those gaps.
Yeah. And what do you think, first, what kind of dashboards and what do you think the roles of dashboards are in an EMR/CRM?
I think it's about giving information, so insights to the user. I think it's a starting point to where we really want to get to in the future. What I mean by that is most common dashboard design is pulling information. It's a bit retroactive once had gathered enough data. And you're usually having to then take a look at the dashboard and change how it's configured or update the views to try to view information a certain way or test the hypothesis that you have. I think where we can get to the next stage of dashboards is twofold. One is make it a bit more proactive, smarter from the system side. For instance, instead of looking back at your past 6 months of claims and figuring out where the payers may have changed the reimbursement rules, why not have the system look to auto detect that, oh, they noticed that this certain reimbursement code with this certain payer is now, right? And they've seen it 20 times starting on October 1st. That's probably a trend that you should surface to the user without the user having to pull it out. Or I think also more codified workflows where the analyst can link to a particular action, link that in an automated way, or at least in a way that the user can just single click to take an action on the next following step. For instance, instead of running a report on patients whose well child visits are due in January, then giving to someone to phone calls to those patients, waiting to hear back from the schedule, flow that into a system that automatically outreaches to those folks, get them in for the well child visit, let those folks kind of self-schedule over a few cycles, also let them know if they moved out of the area. And then at the very end, for the small subset of patients who still haven't responded, put them on a list for your front desk to make a phone call.
Yeah. And I would say before the front desk does the phone call, get an auto dialer built in. So it's just
that's a really great idea for sure.
Auto dialers are great because they just ping and ping until somebody answers the phone.
Yeah.
There's a whole science. They know that people answer the phone between 10 and noon. I don't know why, but that's when they answer the phone. And then again in the late afternoon before they have dinner. The rest of the time they ignore the phone. And it's age driven too. You're not going to get one of George's sons to answer the house phone for nothing. They won't. They'll ignore it. My father will look at the phone and see who's calling the caller ID. And then I'll say, oh, my doctor's calling. And then he'll make a note of it and they'll call him the next morning. And it's a funny conversation. He calls out, he's like, Dr. Rogel called me yesterday. There's this song. What does he want? And nobody knows, right? The person answering the phone is, who called you? Dr. Rogel. But he won't answer the phone in real time. He just takes the note down and then he puts it in his to-do list and he calls tomorrow.
Yeah, that's a generational thing.
It's a generational. It's very different. Aaron, what have I not asked you that you think is important for independent pediatricians to know about software design and software that is important for the success and the value of their practices?
I would say, taking a step back, it's the dream big. Think about what your day-to-day operations look like, how you think about your overall practice holistically, and just think about any way that maybe technology could be able to help. Even if you're not sure, even if it seems almost grandiose, think about those and then see if there are ways to go pursue it. I think that's really a key element of that I would emphasize. I think thinking about your practice holistically and the role of technology is a different frame than saying, hey, can I bring in a better EMR that does something a little better than current system? the traditional kind of EMR focus, I think is really necessary. You need to schedule, you need to write notes, you need to bill, but that's not the only thing that you do in a practice. And that's certainly not the only thing that technology can do. And then as we think about the evolving landscape of how clinical practice is and what patients and parents expect, there's a big role for technology to change that dynamic. That's what I would say as a parting thought.
Interesting.
Aaron, are you going to be in DC in October?
Yeah, no, we will be there. We're quite excited to meet you all at AAP.
What is your booth?
Booth 1116.
Okay.
What was that? 1116?
6.
That's right.
And the company?
All right.
But we're under Develo. So we're a modern pediatric software vendor. Really excited to meet you all, building general pediatric software experiences for independent practices.
Excellent. You'll save the world, hopefully.
And you're coming, right? Is that you're not saying the sales team? You're coming yourself.
Oh, I'm coming myself and other members of the team, not just myself.
Is your engineer going to be there?
Engineers, sales folks, good number of folks from our company.
Yeah. Okay, cool.
We look forward to seeing you there.
Really excited and looking forward to many of you there too.
All right. Thank you for
Thank you, Aaron.
Yeah.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.